Welcome to everybody here in Frankfurt, dear MOI family. I welcome you officially, very officially, as the Dean for Clinical Students Affairs and Education here at the Medical Faculty of the Goethe University in Frankfurt, like every year. So it's a tradition to be here and to welcome you. And again, I shall tell you lots of greetings from the President, personally, of the Goethe University, Miss Professor Brigitta Wolf, who is very impressed what happened here now since about 10 years in Frankfurt at the Dental Institute Carolinum by all the work which was done by Dr. Paul Weigel. You all know him very, very well. And of course supported by his team, his administration team standing here on the right side. Thank you very much. And the technical staff behind, who will guarantee us again a very nice Congress. You all had a long way coming here to Frankfurt, and you have seen that the weather has accepted you, so we will have no raining days, we will have nice days, very interesting days, so that you will, I hope, many take home messages with you if you go back to your countries. Dr. Weigel has again built up an excellent, sophisticated program. I think you will say later more about this. Especially, of course, I'm very honored and proud and pleased to have here our guest speaker, Dr. Homa Sadeh from Los Angeles, United States, from the USC, coming the long way here yesterday. So I hope that you don't have too much jet lag, but as we met yesterday evening, had very interesting, very nice discussions late in the night instead of the long travel before. So welcome again, very cordially, and we are looking later on your presentation, but Paul will announce you more closely. I hope that you will have not only interesting discussions, I hope that you also have a little bit fun during the days and the night events, especially tomorrow in the Villa Kennedy, very close by. Those of you who have been already here, they know this very nice place where we have a very nice evening party tomorrow, where the certificates are presented to those who have passed the long way of the MRI through all classes, courses, and the master thesis. Really a very special event in the course of a personal training and time. I not want to say too much words. We are perfect in time, and I want to hand over the microphone to Paul Weigel to welcome you as well and to introduce you to the program and how you say the Congress is opened. Dear Paul.
Thank you. So thank you very much for this really nice introduction and opening of the 6th Congress of Innovation Jumps in Implantology, what we always organize here as a meeting which is combined with a ceremony for students who are finishing successfully the program. And I have to say first, thank you that this is possible is only because of my staff. They are so great. Please give them applause. In the end of the day, I will announce everybody, and but now we are really eager to hear the first speaker. We already know he's coming from United States. I know him very long, and I think we are a little bit similar. The way of life and also the way of thinking. He's very, very, very creative and a very, very good clinician. I'm only creative, okay? I'm not a good clinician. And the point is, he's also very engaged in making education in Los Angeles. He has a lot of programs. He organizes big meetings, much bigger than this. But the best is that he's an expert in the peri-implant region, soft tissue and crestal bone. And the lecture is talking about that. And I think he's also very innovative. He will also bring in some of his ideas, which he's now realizing, and perhaps it's also coming to the market. We will see. but give him a really big welcome, Homa Zadeh. Bravo. And I already tell him that he should be really honored to speak here, because he's the only one external speaker today. Why? We learn always from you. You know, we have the first, the second, the third alumni congress, and we have a lot of external speakers. Yeah, and they are very good. But we have also speakers from our alumni program, and they were better. And therefore, yeah, today we have only one external speaker, and the rest is all alumni and yeah, program participants. We try this format now, so you are the best. Okay?
Yeah. Thank you, Paul. I'm very honored to be here at Goethe University of Frankfurt. This is really an incredible place, one of the oldest universities, and I'm very happy to be part of this program. I also come from a very old university of Southern California, which is the oldest in the Western United States. Of course, the US is a much younger country in Germany, so we don't have such old universities in US. But I want to first say that congratulations to all of you who've made a commitment to enhance your education, your skills, your knowledge. I think this is a very well-known program, very well organized, the MOI program. It's known all over the world, and I know that it has a very good reputation because Paul is such a great mentor for you. But also, I know that because you attract basically many participants from all over the world, it makes it interesting. There's so many ideas that are different pockets of the world, in the Middle East, in South America, North America, Asia, and when you put it all together, it really makes a lot more sense because we come from different backgrounds with different philosophies, and when you have forums like this, when you exchange these ideas, it's quite valuable. And having an alumni association such as this is quite valuable to keep the camaraderie of this group. And as you will see, some of the people who've been associated with the program for longer give you a presentation. It's inspiring for those of you who are joining the program more recently to see what you can look forward to as you continue to commit yourself to this program. So I think you've made the right decision to take a program such as this because you are continuing your clinical practices, and at the same time you're taking this education. So every time you join one of the lectures and the workshops, you take those ideas back and improve your patient care. So I'm very much proponent of this. I am also a director of the Periodontology Program, where the residents who come to us, they spend 3 years day and night with us. That's fantastic, but I don't think this is practical for everybody, because they have to basically stop their practice for those 3 years to join programs such as that. For those of you who continue your clinical practice, it's much more practical for you to continue your practice at the same time join this educational event and learn and improve your clinical skills. So I'm very happy to be part of this. Paul and I have been friends for a long time, and we've been to so many countries together in different parts of the world, and it's really nice that now we are collaborating, and I'm happy to be here with you today. So since this is a group that very intimate, this is like a family, so feel free at any time as I'm discussing the topic that we're going to be discussing today to ask questions, okay? And that makes it more interesting and interactive. So shall we switch? Very good. So the topic that I selected for you today, it has to do with the interplay between bone and soft tissue. Of course, when we first started with implant dentistry has been about bone, right? So we all know that implants are placed in the jawbone, implants osseointegrate, so we have always focused a great deal on the bone. We do a great deal of work and preparation in trying to quantify the bone. So there are many different classifications for bone quality and quantity. We take a cone beam CT scan, we make measurements of the bone, we select implants that fit the bone, and we prepare our osteotomy, and if we need, we do bone augmentation. So the focus of implant dentistry from the outset has always been the bone, right? Soft tissue has been kind of like this foo-foo stuff, you know, things that you consider for the aesthetics, but hasn't really been focused on in terms of whether or not it's actually important for the health of our implants. So what I'd like to do this morning with you is to really give you a background about what is the importance of soft tissue and how it relates both in terms of the function and aesthetics. Because when we're considering this here, is that we have cases like this. This is my own case. When I look at this case, we have mucosal recession. This has been, you know, an implant that I placed maybe 15 years prior to this photograph. This was probably 20 years ago when I did this case. I placed these implants, and as I see the patient over time, I see mucosal recession and I see marginal bone loss. Of course, our philosophies have changed tremendously. These are the original implants of Brandemark, machined implants, and you know, we have changed in the way of how many implants we place, how close we place them. But nonetheless, when we look at this case, we ask ourselves, obviously there's something that is not ideal with this case, right? There's bone loss, there's mucosal recession. So we have some issues with both the mucosa and the bone. But let me ask you this. What do you think happened first? Was there a bone deficiency, bone loss that led to the mucosal recession? Or do you think that the mucosal deficiency that you see in this case with very thin mucosa, did that have anything to do with the bone loss? First bone loss. You're sure about that? Okay, you started with thin tissue. So you say the mucosa, you say the bone. Anybody else? So she's a politician. She says a little bit of both. Good answer. No, this was just a healed site. Lack of keratinized tissue, yes. So there's a yin and a yang, right? And which one came first? Let's just... Yeah? To be honest with you, I don't remember. Yeah. Right. That's right. Right. So there's bone loss and tissue recession on the teeth as well. Yeah. Mm-hmm.
Hello?
Yeah?
I think we can't only say that the problem is the implant treatment. So I'm asking you this because we have to consider that patient will get old and something happens
Right.
when we get old. And we have to consider this to make a decision and to propose treatment for this patient.
Yeah. It sucks getting old, right? I like getting old. I don't mind it. But yes, you're right that that many patients have conditions that apply overall, and they have the patient susceptibility as an important element of it. I have some patients who are 80 years old. They, you can see that they hardly brush. They hardly, take care of themselves. Yet no periimplantitis, no periodontitis, with lots of plaque over their teeth. So every patient responds differently. So it is very important to understand individual patient susceptibility. So this really brings us to the concept of risk assessment. Before we start treatment, we always have to do risk assessment. So let me tell you a little story of a patient that kind of opened my eyes a little bit. This gentleman came to me and was referred by a restorative dentist who said, well, one of your colleagues, another periodontist, placed these implants. And look how badly they were placed. We need to take those out. We need to start all over again. So we did that. We took those implants out. In fact, we took the rest of the teeth out because of excessive bone loss. And we can discuss and debate that. But nonetheless, we did a lot of quantitation of the bone. We, removed the teeth. We used guided surgery. We placed some implants. And the implants were placed throughout, and where the bone was deficient, some augmentation was done, and we placed these implants, and the prosthodontist in this case restored them. So when the patient treatment was completed, this is how the patient looked. Okay? So the patient had this kind of presentation. As you could see, a very thin mucosa, and he had had a recession in the maxilla. He came back and said, those implants that you placed for me, they really hurt. Okay, my first thought was, well, the inferior alveolar nerve was relatively close. You see here, the inferior alveolar nerve was very close, so I took a CBCT, and I saw that there was still quite a bit of distance between the posterior implants and the inferior alveolar nerve. So that was not the problem. So I asked him follow-up questions. Tell me, what do you mean by they hurt? They said they feel irritated, they just hurt. They're uncomfortable, I'm not happy with them. And I examined him, and I saw some bleeding. The tissue was bleeding a little bit as I was probing around them. So I said, well, let me tell you how to brush better, floss better. And he got really angry at me because he said, I spend a lot of time brushing and flossing. I spend 20 minutes every night with water pick and all of this. And I believe him. You can see that maybe he's even brushing too much because he's caused a lot of recession of his natural teeth. But what is causing his pain? What do you think? Have you had any patients like this? So would lack of keratinized tissue hurt? Okay? You all agree with him? Yeah? His upper teeth hurt. Okay? But he was telling you your implants. It's always, when there's a problem, they're your implants, right? Your implants hurt. Right? Right. Well, I said, no, you bought them. They're your implants now. As long as he paid for them, they are yours. So, okay, so we'll come back to this case. Okay, but I just want to put this in your mind because for me, this was a case that kind of taught me a lesson and gave me some ideas, things that put some concepts together, and that's why I brought this case to discuss for you. So I want to take a step back and just kind of go over the very, very basic information about the relationship between the peri-implant tissues and implants and the restoration. So let's go back to the basics and compare and contrast what we know about teeth and what we know about implants. Okay? Yes? Sure. Right. Right. Well, when they're not osseointegrated, yes, sure. If they're splinted, it is usually, if you do some percussion, you can actually hear that sometimes. Usually there's some inflammation, some probing, increased probing, and you'll be able to detect that. Yeah. But there was no problem with integration. All of them had integrated. So let's compare and contrast teeth and implants with regard to the tissue. First of all, do implants have gingiva? Is there gingiva around implants? Yes, no? Okay. Okay, he takes both sides, yes and no. So you're right every time. Okay, so gingiva only applies to teeth. The term gingiva is the keratinized portion of the tissue around teeth. Implants, technically, we don't refer to that as gingiva. The mucosa around implants is referred to as peri-implant mucosa. Okay? So we say gingiva for teeth, peri-implant mucosa for the tissues around implant. Okay? So there are many elements that are the same, and there are some differences between these two tissues. So let's look a little bit closer and see what is around teeth versus implant. So the attachment of teeth, the gingiva to teeth, consists of what part? What are the tissues that attach to teeth? Epithelium, junction epithelium, and connective tissue. That's correct. How about around implants? So only epithelium, junction epithelium. Is there connective tissue? Yeah. There is a connective tissue, but it's different. The nature of the connective tissue is different. So let's see how the two are different. The people who really defined this was a team of Professor Jan Lindy and Thor Bergland, who defined the nature, the attachment of the mucosa to implants. And the way they described it as two zones. The zone that's right next to the implant and the zone that's a little further away. So let's look a little closer to see what the tissues look like. So when you look at these tissue, you see the zone A, which is right next to the implant. When you have around teeth, how does the connective tissue attach to teeth? You have fibers, right? You have fibers that insert right into the root surface, right? Into the cementum, so around teeth. But implants don't have those fibers that insert into the tooth because there is no tooth or cementum on the other side. So right around the implant, you don't see any fibers. So if you look closely right here, you see right here, you don't see any kind of fibers. Around the implant, you only have cells. So the fibroblasts that are right next to the implant are like pancakes. They flatten themselves out and they're just hugging the surface of the implant. They're not really attaching anywhere. They're just very tight and just like layers of pancakes on top of each other on the surface of the implant. So there's no fibers near the implant. And the fibers are further in. They're deeper inside because they don't have any partner to attach to. And the fibers are running more in parallel to the surface of the implant rather than perpendicular. So some people have basically said, well, maybe this makes implants more susceptible to infiltration by bacteria. Because if you have those fibers attached, they're protecting, they're giving you a very tight attachment, and they prevent bacterial infiltration into the tissues, where if you lack that, you may have more susceptible to infiltration by bacteria. So that remains to be known. So then we had a very nice discussion with Paul about probing around the implants. So do you probe your implants? He will take your degree away, right? You probed, I take your degree away. All right. So, well, I'm not going to tell you what to do, but I'll show you what it means to probe around teeth versus implant. So you see, when you're probing around teeth, your probe can go through the junction epithelium and is stopped by the connective tissue fiber. The connective tissue fibers around the attachment will stop your probe. Okay? So if you have inflammation around the teeth, the probe can even go through the connective tissue, and they are only stopped by fibers that are non-inflamed. What about around implants? Around implants, it's a little harder to probe, right? Because many times those fibroblasts that are really tight around your implant, they prevent your probe from getting in there. So the probe can also go through the junction epithelium around implant. The real problem is that many times the restorations don't even let you get in close to the implant to probe. So many times you are very much challenged by not being able to probe around implant. But nonetheless, if you look at the tissues, they look different, right? And the probing depths are different. Oh. So when you're looking at mucosal thickness, you can see that the mucosal thickness around teeth is narrower. The tissues are thinner. Around implant, the mucosa is thicker. So you can see the mucosa around implants is about double the thickness of around teeth. And the probing depths around implants and teeth are different. The probing depth around implant is a little deeper. So the probing depth around teeth is basically there's less variability because you have the CEJ and you have the bone. You have some cases that have high crest, means that the alveolar bone is close to the CEJ. Some people have low crest where the alveolar bone is further away from the CEJ. So you have these two different types of attachment of the bone around teeth. Around implant, you have a lot of variability because you as a surgeon are placing the implant. So you can place the implant deeper, shallower. Depending on that, the probing depth could be highly variable. So you could have different probing depths based on where you place the implant. You could also have different probing depths based on what the design of the implant is, what's the macro design. Do you have a platform switching implant? Do you have a external hex, internal hex, tissue level, bone level? You have variability of that. Okay, so I tell you what my philosophy is for implant. Is that I think that when you restore an implant, you should always probe the implant soon after the restoration. Because you want to establish a baseline. Because if you just want to probe an implant randomly, it means nothing. You could have 2 millimeters, you could have 5 millimeters, you could have 7 millimeters. It really means nothing. What is more valuable to you is how that probing depth changes over time. That's more valuable. So you want to follow it up over time to know whether or not it changes. So it's important to have a baseline. Also, when you probe, you have to know what you probe. Whether you're probing on the restoration, does your probe reach the abutment? Does the probe reach the implant? So rather than just measuring a number, you use the probe to explore to see where you are. So typically, when I probe, I will go to the depth of the pocket, and then I start slowly withdrawing the probe. And I will see, what am I feeling? Am I feeling the threads on the implants? How many threads? That way, you know if you have threads exposed on the implants and how many threads, and you can make a decision on treating any kind of peri-implant disease in that way. But that's how I would look at it. But I can tell you that usually when this discussion comes up with many experts, you know, you want to get some popcorn because there's going to be a fist fight pretty soon, as there's a lot of disagreement about that, and there's really no consensus. So let's talk about, we talked about the attachment side of the mucosa. So let's talk about the oral side of it. On the oral side, you could either have keratinized or non-keratinized mucosa. Do you think it matters if it's keratinized or non-keratinized? Yes? Okay. Very good. He is very decisive. So he'll know that it does. So how do we know that? Well, there have been a number of publications, some of them better than others. Some of these papers have looked at it cross-sectionally. Some of them have looked at it longitudinally. They've looked at it at different aspects to see if there's any correlation between the presence of keratinized tissue and any other parameters or problems. So I just show you one particular paper that I think is pretty good. In this paper, they followed the implants for 5 years prospectively, and they wanted to know if there's any difference in areas that have either adequate keratinized tissue, which is 2 millimeters in this classification, or inadequate, which is less than 2 millimeters of keratinized tissue, which you see in red. So what they found is that when they look at plaque accumulation, over time, the areas that had less than 2 millimeters of keratinized tissue had much more plaque accumulation. The areas that had more than 2 millimeters of keratinized tissue had less plaque accumulation. Why would that be? What do you think? Why do you think there's more plaque accumulation when the keratinized tissue is inadequate? Right, that's right. If they have not enough keratinized tissue, it hurts. So people avoid those areas, right? Did you have? Okay. So also correlated to that was inflammation and bleeding. Those areas that had inadequate keratinized tissue had more bleeding, which is correlated to plaque accumulation, and they also had more recession. So areas with inadequate keratinized tissue, more plaque, more bleeding, and more recession. So you can see that the 2 millimeters of keratinized tissue seem to be associated with better conditions of plaque, bleeding, and stability of the tissue. So in this study, at least, this was important in a correlation level. So we can look at it in a causal manner to see if there's any causal relationship with that. So this, you suggested that the lack of keratinized tissue is associated with pain. And this was actually studied by Mauricio Araujo, who showed that, yes, those areas that had thin tissue, patients report more pain, especially in the mandible. In the mandible especially, when the tissue was thin, patients complained of discomfort as they were brushing. So they were trying to avoid those areas with thin or less than adequate keratinized tissue. So having enough keratinized mucosa is conducive to better oral hygiene for the patient. So that, I think that's an important point that we can agree upon. But is that all? There's also studies in monkeys where they cut out all the keratinized mucosa, and you can see there's a lot of plaque accumulation, and those areas that had adequate keratinized mucosa had less plaque accumulation. And this was not associated with brushing by the monkeys. So maybe there's something about keratinized tissue that's also conducive to more self-cleansing ability of these areas. And if you have movable, non-keratinized tissue, maybe those areas just have more plaque accumulation because of the nature of the mucosa itself. Nonetheless, we can agree that presence of keratinized tissue is associated with better plaque control and less plaque accumulation and less inflammation. So I think from that standpoint, keratinized mucosa is better for the health of the peri-implant tissues. Okay, so there was a very good study by the group of Professor Klaus Lang, who actually looked at it more in a causal way, in an experimental manner. What they did was they placed some implants in the posterior mandible. They extracted the teeth, they let those areas heal, then they placed some implants in the posterior mandible, and they sutured it up. Excuse me. Thank you. Then, in their experimental group, what they did, they actually removed the keratinized mucosa. So, in the control group, they just placed the implant, sutured it up, there was adequate amounts of keratinized mucosa. But in their test group, they cut out all the keratinized mucosa and they sutured it. And they wanted to know if there's any difference between the two groups. So, first, you can see that on the buccal side, comparing no keratinized mucosa, excuse me, on the right side versus keratinized mucosa on the left side. Is there any difference? Yes. The areas that had no keratinized mucosa had more recession. But that's not all. The areas where they cut out the keratinized mucosa had also more bone loss. So cutting out the keratinized mucosa caused bone loss. Why would that be? You would say, well, maybe dogs are different because they have really thin bone, right? Dogs may have thinner bone. Maybe that's why the bone was more susceptible to bone loss. But they also looked at the areas that had thick bone, 2 millimeters of buccal bone. Even the areas that had 2 millimeters of buccal bone, if they cut out the keratinized mucosa, those areas had more marginal bone loss. What's going on here? What do you think? Yes, there obviously is bone loss. Yeah. Okay, yeah. Yeah. Yes, they had more recession and more bone loss where the keratinized mucosa was cut out. Okay. In this study, they didn't really look at thickness. They just look at comparing areas where they cut out the keratinized gingiva or mucosa versus those that they kept the keratinized mucosa. They didn't really quantify the thickness of that, but that's a good thought. Well, we can come up with a hypothesis. Right now, we don't know why. All we see is that where there's no keratinized mucosa, the tissue is receded as well as there's bone loss. So I'm just trying to get to you guys. I don't want to give it away yet. But
so I would personally suspect it's the quality of the seal that's created attached to gingiva, or the keratinized and non-keratinized. So the seal, there's probably quality, difference in the quality.
in which way?
To seal any kind of bacterial invasion or
Okay.
into going into the rough surface of the implant.
But the keratinization is on the oral side, right? So you think that keratinized tissues that are keratinized on the oral side, on the implant side, they're also different in some way? In which way? Okay, but remember, there's no fibers near the implant. Fibers are much further in. Around the implant, you only have the fibroblasts, you have the cells. But there is no connection between the bone. There's collagen in bone, yes. There's type 1 collagen in the bone. I'm not sure about that. Yes.
So
Yeah.
in this case, ischemia can cause by pressure pulling from the muscle, from lack of volume of tissue.
So why do you think if you cut out the keratinized mucosa, you would have ischemia in the tissue?
Could be from related to from the more mobile tissue, constant pressure during function can cause that. It's a gradual process. Could be inflammation caused by bacteria or a lack of a protective layer. Could be by trauma.
Okay.
Yeah, that's the
So
two
we
that
have
I
a
can
lot of
think of.
hypotheses here, a lot of food for thought and for research. Yes.
In a natural tooth, in cold area, when we have a non-keratinized tissue between two papillae, the number of polymorphonucleic leukocytes, PMN, is very less. I hypothesize that the number of the protection cell, such as a PMN, will decrease in a non-keratinized tissue.
So you think it's because of the host response that is lacking or deficient if you don't have keratinized mucosa. See, you're giving a lot of ideas for research. So I think it's good that you're thinking. It's good that you're hypothesizing. It's always good to ask why. So let's see if we can find any ideas here. Yes.
Keratinized mucosa.
So
And
the
the bone needs
non-keratinized
stress.
mucosa is more movable. Yes, that's
Yeah,
true.
and maybe this disseminates the stress on the bone, and the bone needs stress to stay maintained. rather with keratinized mucosa, it kind of pressures on the bone and keeps it in
Okay,
place.
so a lot of very good hypotheses, a lot of good ideas, and I don't think much research has been done on all of these ideas, but let's see, based on the research that has been done in follow-up, if we can find any answers. Because one thing that keratinized mucosa also has, which is also mucosal thickness, right? Keratinized mucosa is thicker than non-keratinized mucosa. So is it the mucosal thickness that's important, or is it the surface keratinization that's more important? What do you think? Thickness. So, okay, how many of you think thickness is more important? How many of you think that keratinization is more important? Okay, let's put your money out. Let's see. So let's see. There actually is some studies that have looked at it. And that study was done over 20 years ago. And this was done by Ter Berglund and Jan Linde, who looked at the role of mucosal thickness. So this study was around for more than 20 years, but it wasn't until I started to really dig in to see what's going on and put this story together where I went back to this study and rediscovered it and basically put it as part of the clues for this. Because what they did, they placed the implant into the dog mandible, and usually in the dog, mandibular tissue is thicker than maxillary tissue. It's the opposite of human. So typically, on the average, the mandibular mucosa is about 4 millimeters in thickness. So this was their control group, where they placed the implants in the posterior mandible, they closed the mucosa, and that was their control. In the experimental group, what they did was they thinned that flap. They didn't remove the keratinization like Klaus Lang did. They didn't remove all the keratinized tissue. All they did was to thin the flap so that the surface keratinization was untouched. It was just a thinner flap. So some of the flaps are 4 millimeters in the controls. Some of the flaps are 2 millimeter in the experimental. Okay? And they compare these, and they let them go for 6 months of healing time. So over a 6-month period, they basically compare these, control and experimental. What do you think happened after 6 months? You could see thick tissue and thin tissue, both exactly the same amount of keratinization. Okay? So you can see the control group where they had thick tissue, very stable bone, very little bone loss. The areas that had thin tissue, they had marginal bone loss. Why do you think that is? Vascularity, okay. Okay, so what about the attachment? Okay, so what about the biological width? Okay.
To give room to the biological width.
Okay. Very good. I think you're right on the target. I believe you're right on target, because what happens, you see, that, huh? Yes. Always, yes. But I like that you had very divergent ideas, you know? And, you know, I don't say yes or no to a lot of them because they haven't been studied. You know, I think a lot of these are valid ideas that should be studied over time. But you can see that where you had thick tissue, the biological width was established supracrestally, right? There was enough tissue height to establish that biologic width supracrestally. But when the tissue height was too little, the tissue was too thin, there wasn't enough tissue height to establish a biologic width supracrestally, so the body resorbed bone to establish that biologic width subcrestally. Why is biologic width so important? Yeah, that's right. It is absolutely critical to our survival to have a very tight biologic width or attachment. Now, by the way, the term biologic width around teeth went away, and there was a new classification from American Academy of Periodontology and the European Federation of Perio. The new term is a supracrestal attachment. They haven't revised that for the implant, but I anticipate that the supracrestal attachment will also be revised at some point to make it also the same thing. So you could see that biologic width is consisting of what? What does biologic width consist of? That's right. So biologic width is consisting of that junction epithelium and the connective tissue attachment. Okay? So it's really important to establish it to prevent bacterial infiltration into the tissue. So if you have enough height supracrestally to establish that biologic width, that's great. But if you don't have enough tissue height, the body will resorb bone to establish that biologic width subcrestally. Okay? So, and that's what happened. You could see that in the histological images, you could see that bone loss in order to establish that subcrestal biologic width. The magnitude of the biologic width is the same. It's just that when you have thick tissue, it's supracrestal. If you have thin tissue, it becomes subcrestal. Okay? Yes?
Side with the thicker tissue is more stable versus on the long term. Once the biological width is established, they become the same.
I will show you some human studies that have that. They don't have the histology, but they do have. There's some human studies that will look at that. I will show you that.
Once the biological width is established, they're the same?
It is more stable, yes.
No, I mean they become the same.
Yes, the thickness of the biologic width is the same, regardless if you have...
The thin tissue, and then the bone gets resorbed. The bone gets resorbed to establish the biological width.
That's right.
So once the bone is resorbed and the biological width is established, it becomes stable. Is it as stable as the one with the thick tissue or not?
We don't know what would be the long term, because what could happen, a lot of times it's a trigger. So maybe because you had this trigger of that initial bone loss, maybe this will start down the line further bone loss. But we don't know that. But these are very good questions that I think need more studies. But when we used the, let's say, external hex implant many years ago, we routinely found that there was bone loss up to the level of the first thread. And then there were, in some patients, it didn't go further. In other patients, it continued. And we didn't really pay attention enough to know, was it due to having thin tissue that those progressed versus those that had thicker tissue had more stable. But that's a good question to follow up these cases to know whether or not once you get that initial bone loss, because of the thin tissue, Does it continue or does it stable?
Body to accommodate why it's not.
That's right. So it's very similar to when you have invasion of the biologic width, when you put your restoration subcrestally or subgingivally. So if you invade the biologic width of teeth by placing subgingival restoration, the same thing happens. You get resorption of the bone in order to establish that biologic width subcrestally. Yes. Right.
But it's 22 years ago, we have mostly this kind of design.
Yes.
And, you know, the question is, if you now change the design to, let me say, smaller abutments, platform switching, subcrestal placement, you get more room for a thin soft tissue, right? That means even you have, in the beginning, a thin biotype, but you place the implant deeper, and you have platform switching, yet you have more room for the biological risk establishment, and then it's also protective against crestal bone loss. Do you agree on this philosophy? Because we have not really a perfect literature on that. We have only hints on some literature if you put together this puzzle.
Well, there is actually a study by Thomas Linkovics exactly on that topic.
They had a lot of bias in it.
Yes, but yes, but I will actually just show you that just as a way of what they have found in that particular study. Let me just show you what they found. They have
the MOI mode. A question.
That's right. That's right.
And
Well,
you search the literature for that.
no.
Don't you can continue your lecture because
No, but I think that's
we have only
an important question that you had. It's not a perfect, you know, demonstration of that, but here.
students
Okay,
know
here.
the study.
Okay,
They
yeah.
know the study
Oh.
because we have it
Oh.
already.
This one. This is the study where they looked at platform switching. So influx of mucosal thickness on platform switching. What they found was that platform switching was associated with less marginal bone loss if you had adequate mucosa. But if the mucosa was thin, it didn't seem to protect against marginal bone loss. So in the thin mucosa, platform switching didn't work. It only needed. Yeah.
This is the combination.
Right.
Yeah, platform switching plus a little bit subcrestally
Right.
and thin biotype. Then you have the room for
Right.
the biological risk.
Yeah. So that's the key, that you have to place it subcrestally in order to establish that biologic width, which is the same thing
Yes.
as Mother Nature will do to cause that subcrestal bone loss to establish that subcrestal
Okay.
biological width. Yeah.
Why should we do crown lengthening then?
Okay. Because periodontists need to have a job. So that's a good question. Okay. So if you think that Mother Nature is going to do that for you, that's going to cause the bone loss and is going to move the attachment down, why should we do the surgery to actually do the crown lengthening surgically? Let Mother Nature take its course. The answer is that when you violate the biologic width and you're going subgingivally, what will happen is that the time that it takes for that bone loss to take place is a miserable time for your patient. That's the time that the patient is always in pain and they say, damn that dentist who did this for me. It hurts. They're uncomfortable. Okay? So they're going to be very unhappy first with the inflammation, but also what will happen after that, it will happen with the pocket. So they get a bone loss, they get a pocket, and that pocket may not stop progressing, and they may continue to progress, and they may lead to more periodontal attachment loss down the line. So, well, it may happen as well with the implant, that if you have initiation of the bone loss, it may also progress. That's why it's important that at the time of placement of the implant, we anticipate all that. So if we think that we need certain mucosal thickness, we establish it beforehand, so we don't allow nature to cause that for you. You want to create it for nature, knowing that you need this room for the biologic width, so you don't allow nature to create that for you.
I'm very happy that you actually finally, we're talking about soft tissue here, because my master's thesis in Goethe was the importance of keratinized mucosa around dental implants, and I compared the strip technique with an onlay connective tissue graft, and with my little experience with this work for the last 7 years, I kind of a little disagreeing about the thickness might be playing an important role, despite that there's a lot of studies, but I can see purely in this study that was a split thickness flap. I think, personally, I mean, I didn't do many studies myself, but splitting the thickness of the flap, that's it. Yeah. This is number one. Number two, I think it's more about the length of how long is the keratinized mucosa rather than the thickness. If it's really, you have decent length, that means we have more protection rather than how thick it is. And was part of the of my master's thesis in here was to actually try to diagnose the amount of keratinized mucosa that I gained. And I used a very simple technique, which is staining it up with Lugol solution, and which stays. And I can see from long term, now I have at least 10 cases for over the last 2 years. And I'm still following it up because I'm still
You measure the thickness of the mucosa also?
The thickness of the mucosa, there's quite thick in some cases. It is part of the measurements, but I'm more focused on the length of how much keratinized mucosa I got, because I can get significant thickness. I can get it really thick. I have pictures. In posterior mandible, like this case, I have really thick mucosa, but I don't have much length. It didn't make a difference with a thinner mucosa with longer keratinized mucosa, and it's been already 2 years. So I will. It's gonna be published with Geislich, but I'm just pointing it out that I with all respect with the just the technique, I didn't really like that it's the split even if it's 5 mil thickness, if it's a split thickness, it will get recession.
So
and,
there is that debate about thickness versus keratinization, and that's still not resolved because I think people are still questioning that. But I think one study that really looked at it more directly was this particular study by Legavikas, where they looked at the issue of thickness, because what they did here in their study, they had patients who had thin mucosa, right? And they had some patients that had thick mucosa. And what they did was the cases that had thin mucosa, they thickened those therapeutically by doing a tissue graft. But what is interesting is that the grafting technique was using an acellular dermis graft, an allograft. Now, allograft, we all know, that will not cause surface keratinization, right? So it is only increasing the mucosal thickness. So they were able to create thicker mucosa to create this augmented thickness. So when they placed the implants into thin, into thick, and into augmented thin tissue, they compared what happened to the marginal bone. And interestingly, what they found, what happened to the marginal bone is that after 1 year, the areas that had thin mucosa, this is very clear. Thin mucosa, there was increased bone loss. This is very, very important. Thin mucosa had increased bone loss as anticipated. But also, the thick mucosa, those areas that had naturally thick mucosa, had much, much less marginal bone loss after 12 months. What is the most interesting group is the group that had augmentation of the thickness. Those had just very little amount of bone loss, the same as those that had naturally thick mucosa. So I think this study argues the fact that it's the thickness that matters more than the keratinization, because in this study they didn't do anything to augment it. Yes.
I just want to give some attention that as Dr. Paul Weigel mentioned, because your study is focused on the non-platform switch implant, and you get all this kind of bone loss and keratinized tissues recession. I only use ankylose for 18 years, and I don't have this trouble. I don't have much peri-implantitis, almost none. So I sleep very peacefully because of the ankylose have the platform switch. And we have very thick and enough volume of soft tissues around the ground that protect the bone and also protect the inflammation. So it's very much different.
Yes, that's a good point, because as Professor Weigel mentioned, is that the concept of ankylose is to place the implant subcrestally. So by placing the implant subcrestally, you are already creating that room for your biologic width. So maybe in those situations where you are creating that space by placing a subcrestal implant and creating that space for the biologic width, you may not have the need to do the soft tissue augmentation because you already are creating that room for that. So I think, yes, that would be a good idea to do study with different implant designs to see if that matters for different implant designs.
That putting subcrestally can increase the room for the biological width, but even you put in the bone level with the ankylose abutment, that is cortical connection, and you have platform switch, so we still can maintain the bones and the soft tissue stability for long time.
But just to be the devil's advocate, I think the concept of the platform switching, I think we're getting a little bit off topic, but just to go back to that, there was a very recent study by Hugo de Bruin and their group where they compared on the same implant with the same design, same surface, everything, one side platform switching, another side not platform switching, seeing no difference. So sometimes I think we focus on the implant designs, but I think we need to focus more on the biological concepts that are much more important than the implant design. So I think, but the concept here of focusing on keratinization, because many studies have been done, one by Mario Rakutsu, who followed up implants where he did soft tissue augmentation using a free gingival graft, and he found that the group that he grafted had better tissue, better bone level as well. That's also very important. But you see, when you do a free gingival graft, you're increasing the thickness and increasing the keratinization. So there's no way for us to distinguish what is more important. And I think if you ask many clinicians, many will say, well, it's the keratinized tissue that's more important. Others will say it's the thickness that's more important. Which one is more? I think what we have to go based on is what evidence we have. You know, the reality is that what I'm showing you is all the evidence that we have. I think it's definitely an area that's warranted to do more studies, and I think it's important to do additional studies. But I think what we have to look at is especially the evidence that's experimental is very important. And one of the experimental studies was a follow-up done by on the teeth to look at whether or not doing soft tissue augmentation around teeth is important, and then we'll compare around implant. So you know that this is a very good study because this was a up to 27-year follow-up of patients who had recession. On one side they treated, on the other side they didn't treat. And they followed up these patients somewhere between 10 to 27 years. What they found out is that the sites where they had no treated, control sites, what happened is that where there was a recession, it continued to increase. And that's what we know as a risk assessment for teeth. The most important risk factor that will determine future recession around teeth is the presence of existing recession. So if your patient has a recession, they have high likelihood that the recession is only going to increase. Okay? So that's a risk factor for recession. Now, when they compare the experimental side, where they did a free gingival graft on these patients, and they looked at the treated sites, you could see that with the treated sites, they had root coverage a little bit, not a lot of root coverage because what they used was a free gingival graft, which is not ideal for root coverage, but their recession decreased in sites that they had done free gingival graft, and over time their root recession was very stable. It didn't change. And the amount of keratinization was very stable. So this study showed that treatment of gingival recession is very effective and leads to stability of the tissues around teeth. Now, does the same thing happen around implant? Is treatment effective around implant? Well, this is the same study that was done by Klaus Lang, where they cut out the keratinized mucosa around the implants before they sutured it. What they did was they tried a graft around it. And where they got the graft was from the canine in the maxilla. They took a canine from the maxilla and they used it to graft the areas where they had cut out the keratinized mucosa around it. But they did two groups. On one group where they removed that free gingival graft from the canine, on one group they removed the surface keratinization. So that means that the graft was a connective tissue graft without epithelium. Okay? And in another group, they left the surface keratinization and the epithelium, so that was a epithelialized or a free gingival graft. So they did these two types of grafts around the areas where they had cut out the keratinized mucosa. Okay? And they did the test. Okay? They placed them around the implants where they had cut out the keratinized mucosa. So which group do you think was more effective? Where they left the surface epithelium on there, or where they removed the surface epithelium? Same? Anybody else? Okay. No, he's the winner. Yes. There was the same. No difference. No difference. Whether they kept the surface epithelium or not, it didn't matter. So this focus on keratinized tissue doesn't seem to matter. Because when they remove the keratinized tissue from the donor sites and they use it for the graft, that was just as effective as where they kept the epithelium on there. So whether you use a free gingival graft or use a connective tissue graft to augment the tissue around the implants, they're both effective. Okay? Yeah. 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 Well, they're both left as a bilaminar. Basically, they put them both under the flap. Yeah. But what is interesting that they say that neither one increased the surface keratinization on the tissue. Neither group. Nonetheless, they're both effective at reducing the amount of bone loss in these areas. So I think this is additional evidence that what's important is the mucosal thickness, not the surface keratinization. Because just increasing the mucosal thickness, previously by Lekavicus using an allograft or using a connective tissue graft, in this case, they're both effective at reducing the amount of bone loss. So,
any of the studies that showed with measuring the thickness, the level of muscle attachment too, or just talking thickness?
No, they just...
Only how thick it is.
That's right.
But, I mean, if it's really thick and you have really high muscle attachment, wouldn't you think it will be effective?
Well, these are not really thick because they came from the gingiva of a canine. So they're both relatively thin grafts.
I'm talking generally. Like,
Right.
I mean, if the muscle is really high and you have a really thick tissue, wouldn't you think it will be sort of...
Well, I will show you how I manage it, so you could see how we would manage this kind of graft. And I think we dissect the muscles away typically, but we don't really pay attention to the frenum. I will explain the frenum attachment. I think that's also an area that people focus on. So I will show you about that. I think that's coming up next. This is the techniques. So what are the different techniques? There are different techniques for soft tissue augmentation. The classic way is the free gingival graft. I think that's really the classic way of augmentation, is using a free gingival graft, because that increases the keratinization, it increases the thickness, it increases the vestibular depth, it does everything, right? But also an allograft or xenograft, they're used to thicken the mucosa without surface keratinization. Now we also have other tools for us, such as LPRF. We had some discussion about the role of LPRF. I think there's still a lot more that we need to learn about LPRF. And right here in Goethe University, you guys are doing some very amazing work on LPRF. So that would be another area to investigate the effect of LPRF in this area. And today we won't cover that, but next Wednesday in our discussion, we're going to talk a little bit about flap management. A lot of times by managing the flap and making some pedicle incision design modifications, we can really increase the mucosal thickness. And using the VIP graft, the vascularized type of graft, I will show those to you on Wednesday. The same group will be here on Wednesday? No. Okay, sorry. So you have to stay if you want to see them. Oh, and we have the technique of VISTA, or vestibular incision, subperiosteal tunneling. And so we have many different techniques available. I think, you know, we all have our own personal biases based on what we prefer. And I think in many areas, a lot of it comes down to personal preference. What do you feel comfortable with? You want to do a free gingival graft? Go ahead. You want to use a connective tissue graft? They both work. It's just that there are some differences. What are some differences in the outcome? The free gingival graft is the classic way, taking tissue from the palate using an epithelialized graft from the palate and grafting it on the recipient site. Okay, so epithelialized graft that is placed on the recipient site. This is very effective at increasing the thickness, increasing the vestibular depth, and increasing the characterization. It's only one problem. It's ugly. Okay? It's very ugly. This is one of my patients who had a graft, very attractive lady, but as she's talking, all I can see is this tire patch sticking out of her smile. It really is unfortunate. So this is definitely not something you want to use in the aesthetic zone. Okay? So if it's in a non-aesthetic zone, this is fine. Many people still use that, but this is not my preferred technique. But let's say here, if you have an overdenture or some areas that are not in the aesthetic zone, free gingival graft is a great technique. It's very, very effective. You just have to make a basically partial thickness dissection, leave the periosteum behind, okay, on the bone. But even if you remove all the periosteum and you place the graft on bone, it's also effective. So you don't have to have a periosteum on the recipient site. So you can harvest from the donor site, suture it in place in a stable manner, and it is very effective. This is done by one of our residents, Navid, and he, you see, was able to get a very nice thick band of keratinized tissue around the site. So free gingival graft works very well. Okay, and I think many people prefer to use this technique. For me, it's a bit invasive, it's unaesthetic, and I think that for me, I prefer to use the connective tissue graft. So you can introduce your graft through different means. You can introduce it through an intrasulcular tunnel. You can make a tunnel through the sulcus of the teeth, or in the case of the implant, around the implant. It's just very challenging. Okay? Many people prefer this technique. I'm not a big fan of that because it's very challenging. You can just do a coronal advancement flap. You can do a partial thickness flap and place a connective tissue graft in there, or an allograft or a xenograft in there. Or you can use a VISTA technique. VISTA stands for vestibular incision subperiosteal tunnel. So you will be there in the workshop tomorrow, right? Okay, so in the workshop, we're going to go through the step-by-step and really, learn the technique, because I think for me that's the ideal technique. I published on this about, I think, 7 years ago in 2011, but before that I have cases that are more than 10 years with follow-up. This is a very effective technique around teeth, around implant. VISTA stands for vestibular incision subperiosteal tunnel access. So the vestibular access has been published before by Fuad Khoury, right here in Germany, a good friend, and also others. But I basically developed the whole protocol as using VISTA as a vestibular access for both bone and soft tissue augmentation. So in this case, when we're trying to get some root coverage around teeth, we first started with teeth, and then now we use it quite a bit around implants. So I'll show you how we use it around teeth first, and then I'll show you what we do for the implant. So if we're trying to get some root coverage around teeth with VISTA, we make a vestibular incision if we're dealing with the maxilla, we would make an incision typically in the midline frenum area. We make our subperiosteal tunnel. That means full thickness dissection. We make it easy because many people try to do partial thickness. It's hard. Partial thickness is hard. But also, most of these cases that we're treating have very thin mucosa. If you have thin mucosa already, why do partial thickness and thin it even more? So we just go for full thickness dissection. It's easy. It's also important because we are not disturbing the blood supply. We are keeping the mucoperiosteal complex together. So subperiosteal tunneling. We'll talk more detail of the technique tomorrow, but we make a subperiosteal tunnel that continue going posteriorly. Also, we go interproximally to lift the papillae away. So basically, you are separating the whole mucoperiosteal complex away from the bone, creating a tunnel that is underneath the periosteum and between the periosteum and bone. So next thing is that if we are treating recession defect, we are coronally advancing the tissues. When you coronally advance the tissues, you don't want the tissue to go back up. You want to fixate it. And this is a very important step. You will suture each tooth individually, and we bond each suture individually to each tooth. So then we are fully controlling the position of the gingival margins around here. Because you don't want, as the tissue moving up and down, to control the position of the tissue. You fixate it.
Pinhole.
Yes. Well, pinhole technique came after this. So I think there are some elements that the pinhole, I think, has similar to this, except that this technique has more control because you make an incision, you have a direct access. With a pinhole, you puncture through the tissue with the instrument, not.
Yeah, tissue.
So this technique, one of the key important aspects of the VISTA is that we are bonding the tissues with sutures. I think that, personally, I think pinhole is a gimmick because they try to not to tell the patient that, oh, this is incisionless, it's without any sutures. But I think the sutures are a key aspect because if you doing bone augmentation, you never think about not stabilizing the bone. Same thing is true. When you do soft tissue augmentation, you have to stabilize the tissue. Otherwise, the movement of the muscle is going to move everything up and down. So stabilizing it is really the key if you're trying to get root coverage. So we fixate each tooth. So this technique has the bonded sutures to the teeth. Now, the technique of Otto Zur and Hertzler, they also use a bonded suturing, but they bond to the interproximal area. I like my technique better because the midfacial is the more important area that you're trying to fixate, and it's much easier to fixate these sutures. So tomorrow in the lab, you're going to actually do that on your specimens that you're going to get the bonded suture. Okay? So this is very important aspect.
So pinhole creates more scarring.
Well, they don't do a graft. They place a collagen membrane in there. Okay? So I can't speak from experience because I have never done it, but also as far as I know, there's no publication on the data or on the study. We have now a clinical trial comparing different techniques of root coverage, and Vista has been much more effective than other techniques. So
Advance the tissue, but you don't put anything.
yes, we do. Yes. In this technique, I'm going to show you. First, we position the tissue, and then we're placing our graft. Now, you have many choices of grafts. In this case, I use an allograft. You can use a xenograft. You can use a connective tissue graft. So tomorrow we'll discuss more about the choice of graft, but they all work. We just had a paper published in the Journal of Aesthetic Restorative Dentistry demonstrating that all of the grafts that we worked with, either connective tissue graft or allograft or xenograft, they all work very well.
Because you're below the periosteum in this case, the blood supply is still coming from the periosteum, but from underneath?
Yes, so you are getting inside the tunnel, you have very good blood supply. The bone actually still has also circulation of its own, but the periosteum is giving quite a bit of circulation. Everything is contained. But also remember that we didn't make any surface incisions. So the blood supply inside the tunnel is very, very nice. So usually when you do this technique, within a day or two, when the patient comes back, the tissue looks beautiful and like unaltered. So that's why the blood supply is so important for this.
Try the technique without grafting any material?
Yes, we can also use it without the graft. There was just a paper by Giulia Rasparini that looked at coronal advancement without the graft with 9-year follow-up. That works. The decision maker for us is how much tissue thickness do we have, how much, and that becomes the key, whether you have keratinized and thick tissue. If you have that, you don't have to use a graft. But typically, most of these cases have lots of recession and because of having thin tissue. So for me, if I'm getting in there, I might as well thicken the mucosa anyway. So I don't have to go to the palate necessarily for these, but I would use either a xenograft or an allograft just to thicken the mucosa. And the good thing about this technique is that you can do full arch. You can do a full arch augmentation in the same setting.
And in long-term results, you can compare with the same tunnel technique when you use, let's say, allograft, mucograft. The results are not the same. After, I have this experience after 6-7 years, the width of the tissue is completely better with connective tissue graft, especially when you connect this treatment with ortho treatment. So the results are much, much better. Of course, in some cases when we don't have enough tissue because we have full arches, it's a good idea to have, let's say, allograft, mucoderm, whatever, but I think the connective tissue is the best. And I have another question to this method. In this particular method, because I have discussion with Sur and also with Professor Tsukeli about this method, don't you think that later on, looking on the aesthetic design, we have a kind of fault when you have gingiva and you're making this method, you have a kind of fault on the upper part of papilla. But making traditional tunnel from another part, we don't have this fault because we can better, let's say, mobilize the papilla.
So one by one. So if you're doing full arch, right? How many of you would like to hide the whole palate to put in the whole arch? You know, it becomes a practical matter. If you're doing a large area, it's just not practical to get that much keratinized connective tissue. Of course, I agree that the best tissue is autogenous tissue, but it becomes a practical matter that if you have a large amount of tissue, it's just not practical to use all of that. So practically what we do, if we have some areas, and we don't have time today to talk about the whole risk assessment, but if there are elements of major risk, that we have those areas that have very thin tissue, prominent roots, that we're planning to orthodontic and so on, we can use a connective tissue in those cases. But typically what I use is not from the palate, but more from the tuberosity. Tuberosity is actually the most effective, and tomorrow in the workshop I'll show you how to utilize the tuberosity, and you can actually get a lot of tissue from the tuberosity. So, you know, it becomes a practical matter. But in terms of the folds that you may get in this case, if you get fold, is because the interproximal dissection was not enough. But if you actually compare the different techniques, the biggest problem is with the making a papilla incisions that comes with the coronally advanced flap, because there was actually a study by Otto Zur and Hertzler's group that showed 25% of those areas where they had the papilla incision for coronal advancement flap, they had scarring left behind from the incision that was in the papilla. So because this technique does not make incision in the papilla, it actually has the least amount of scarring of any technique. Now, I disagree that the intrasulcular technique actually has worse results, and the primary reason is that when you go into the sulcus, you're going to be traumatizing quite a bit the sulcus. So it is really difficult, especially if you're doing one tooth. I can understand that the intrasulcular tunneling can work. But if you're doing a full arch to do tunnel for every single tooth, for me, it's insane. If you have one incision and you can make all of it, and for that incision go through the whole arch, that's much more efficient way rather than going single tooth at a time. And especially if you have exostosis, you have any kind of obstacles to that, it's just not practical to do this intrasulcular, especially, you know, because of the sulcus doesn't give you enough release. If you don't have enough release and you cannot do enough coronal advancement, now Hertzler's technique is involving palatal tunneling subperiosteal, or the partial thickness dissection from the palate. It's a very complicated technique. So I think there are different ways. There are some really outstanding clinicians who do very well in all techniques, but I think if someone is happy with intrasulcular technique, that's fine. You can use it. If someone's happy with you know, coronal advancement, that's okay. There are many different ways to accomplish that, and there are really outstanding clinicians. You know, Professor Zucchelli is a fantastic surgeon. He does beautiful work. He can really make that technique work like nobody else. It's really fantastic. Hertzler and Zur are fantastic surgeons. They do a beautiful job with intrasulcular tunneling. If it works for you, by all means. That's why I say there are different techniques. You have different ways. This is what I do, and this is what works. And you can always evaluate for yourself to see what works for you. And you have options. That's the good thing with clinical dentistry, is that you have many options. So here, you see at the end of the procedure, you have the coronal advancement, you have the stabilization of the mucosal margins, and you can see that the graft was inserted. And after the suture removal, you can see that the tissues generally have very healthy appearance because we don't really alter the blood supply. The blood supply is very good, and you see the patient comes back after 1 year, complete root coverage. But what is important is that the thickness gain. The thickness gain is something that we focus on. So we see that, you know, the interproximal area, you look at 1 year and it looks like we had papilla gain. But what I want to show you is that the papilla gain that you get with any technique, I don't care who's doing it, what material, what you're doing, the papilla gain is not predictable, okay? Because the papilla is dependent on interproximal bone. And if there's no periodontal attachment interproximally, no matter what material you put in there, it's not going to be stable over time. So we don't make a commitment to patient that we can regenerate the papilla, because if they are concerned with the black triangle, the most effective way is to either do ortho or restorative dentistry or a combination of. But what I want you to look at here is that the thickness gain is very stable over time. So let's go back to our patient. Why was our patient in pain? What was causing this pain? So the pain can come from the discomfort of brushing because it's uncomfortable to brush, but also it comes because he's experiencing marginal bone loss. There is bone loss that occurs in the process of establishing a subcrestal biological width. That's why I say we need to augment the tissues to try to make sure that there's no marginal bone loss during the healing. Okay, so you want to augment the tissues, you know, as a way of preventive measure at the same time as the implant placement. So in this case, you can see that when the patient came back, even though his hygiene was great, you can see inflammation. There's no plaque there, but there's inflammation because inflammation is induced by the process of bone loss. Okay? So there is bone loss as a result of that thin mucosa. So honestly, at this point, I was desperate. I, you know, didn't have the full idea at this point yet, and I just did the best thing that I could do was to do a soft tissue graft. And I use a connective tissue graft. I use a very thick connective tissue graft from the palate, and I use Vista. So in the posterior mandible, the position of the tunnel is a little bit different. So I typically make the incision anterior to the canine because you're trying to avoid the mental foramen. So in this area, as we dissect not straight back, but we slide under the attached mucosa, and we slide under the attached mucosa near the mucosal margin. And we slide back, and we have special instruments that you'll be able to play with tomorrow. And you see we inserted inside the tunnel and have thickness gain in this area. Now, what I want you to look at is the vestibular depth. Look at the frenum attachment. Initially, you have very high frenum attachment. And people say, oh, do you have to do frenectomy? No. Usually when you do Vista, the frenum will disappear. No, in the anterior area where we make the incision, you get a scar in the area of the incision. So the maxillary anterior, the position of the incision is in the midline frenum. So we don't cut out the frenum, but we use the frenum as an initial access point for the incision, and you get a scar in this area. But you see, what happens is that as you're creating a tunnel subperiosteally and you place the connective tissue graft, you still have the surface mucosa that was always there from before. So the surface mucosa is not altered, okay? But also, one of the important studies that was done in the 1970s by Klaus Lang and Lowe, and what they found was to look at what is the element of the tissue that causes epithelial keratinization. What gives a signal to the epithelium to become keratinized? Is it the epithelium or the connective tissue that signals surface keratinization? The connective tissue that comes from an area that is keratinized, like a palatal tissue, that connective tissue has within it the signals to signal the surface to become keratinized. So technically, the connective tissue that we inserted here should signal the epithelium to become keratinized. Why is it not doing that here? Why is the surface not keratinized? Because we place it very deep. In Vista, we place it subperiosteally. So you have the connective tissue, but it's under the periosteum. So, excuse me. So you have the connective tissue, over that you have the periosteum, and you have the epithelium, right? So it's not enough, there's too much distance between the connective tissue and the surface epithelium to signal that epithelium to become keratinized. So that's why it's not becoming keratinized. Yes, you can, but why? Just because, yes, you see, that's why what I like to do is hopefully change your paradigm, not to focus on the surface epithelium. Because what I was doing in the past is that sometimes when I was doing this and I was working with the referring dentist and say, but the surface is not keratinized. And I bring the patient back and do dermabrasion, remove the epithelium, and what will form is keratinized. So that's what smoking is different story, because smoking increases the mucosal thickness. But the point that I'm trying to make to you is that don't be so focused on the epithelium characteristic. All we care about is health. If you care about health, if you look at the tissue here, it's very healthy. There's no inflammation, okay? The mucosa is thicker, the vestibule is thicker, the patient is more comfortable, the pain is gone. So rather than saying the outcome of our therapy should be establishing a keratinized tissue, why do you set that as an outcome? We don't need to set that as our endpoint. You set the endpoint whatever you want the endpoint to be. And if your endpoint is health, aesthetics, and doing the least invasive surgery for your patient, you don't need to do another surgery to remove the frenum. You don't need to do another surgery to, just to see that keratinization. But also, you don't need to split the tissue, because if you're splitting the tissue, it means that you're doing procedure that is disturbing the blood supply. The best blood supply comes when you're keeping the mucoperiosteal complex together. And if you're not disturbing it, the healing is much better. So, so don't change your technique, change your paradigm. Your paradigm should be health, and that's what you care about. If you are interested in health, increase the tissue thickness rather than increasing surface keratinization. And you see, we did the same thing for the other side. And you see again, the same thing. You can see very healthy tissue that is established, deeper vestibule, and thicker tissue, more comfortable for the patient. Yes? No, this is not temporary. These are... Yeah. But these are...
Would be better. For me, it would be better to remove the abutments and place this connective tissue more at the top of the implants, right, not just vestibulary.
Yes, if there are areas that are in the aesthetic zone, we do bury the implant and to try to cover in that area. Yes, it is. If you're trying to do that, and there are some cases that we do that just to improve the aesthetics in those areas, to bury the implant. In this case, unfortunately, this is cement retained, pretty long abutments. To remove them, the restorative dentist will kill me to cut out the restoration and damage it. Then I have to redo his restoration for him. Yeah.
So, Professor, in this particular case, I'm just wondering. So you have you still have mobile mucosa there, don't you?
Yeah.
So you don't really care about this part.
Well, again, focus on not what is mobile, where is it mobile. The mobility is on the surface.
Okay.
What we care about is not what is in the absolute surface. What we care about is what is adherent to that implant. Okay? In the deeper layer, what is, you see, initially when you have the mobility is in the attachment to the implant. What you care about is not what is on the surface that you see, is actually in the deeper layer, which is what's attached to the implant. So if you actually move the vestibule, you will see that the vestibule up to here, up to this point, is very stable. You can see that this is all deepened vestibule. So if you try to move it, it moves. But again, you're fixed on your paradigm. Your paradigm is to establish that keratinized tissue. They focus on health. If you're focusing on the health of the tissue, which is reducing inflammation, making it comfortable for the patient to brush, and making it comfortable for the patient to maintain this with thicker tissue, that is what is objective. But if you want to do, again, I said that to you in the beginning. If you want to do a free gingival graft, they will do all of those things. You're free to do that. That's a good technique. I'm not criticizing that. That's your option. But I'm giving you additional tools, and you can choose any of these in your toolbox that you choose to use as you treat your case. So, we also do soft tissue augmentation for aesthetic enhancement, right? Okay.
Some questions?
Yeah, sure. Yeah.
We have a very nice discussion here in the room.
I like that.
Yeah.
That's what I like, is that it's interactive.
And they forgot about the lunch break. So I think we should continue. Please make the next topic on top.
Okay.
Yeah. But only some questions, and then please also in the lunch break you can start to have personal questions to him. Yeah.
Sounds good.
Because otherwise we run completely out of the time scale. I don't want to interrupt you too much, yeah. But I think you should.
Okay.
What you want.
Sounds good. So
the cage, perhaps.
Yes, if you want to. Okay, so I think maybe we go to this topic of how do we manage around extraction socket, right? Because also we look at what happens to the bone after extraction, but we also have to look at what happens to the mucosa around implant. around the site. Yes. Yeah. Right. So once we took care of that with that connective tissue graft through the vestibule, all of those symptoms were. Well, the debridement, because there was no bacteria, there was no plaque, there was no. So in some cases where we have established periimplantitis, we have to treat the implant surfaces that are contaminated. We do implantoplasty in some of those cases. In this case, it was not. All right, so Paul has asked me also to talk to you a little bit about how we manage extraction sockets and what happens to the tissue. This is a nice study that was done by Danny Boozer and their group. And in their studies, they found that after extraction, depending on what is the initial bone thickness, you lose the mucosa also changes. You see, you have after extraction, you either have thick bone or thin bone. The areas that have thin bone, you see, the bone resorbs away. The areas that have thick bone, excuse me, the areas that have thick bone, the bone remains. But also what happens is that the mucosa changes. You see, the phenotype of the bone, either thin or thick. So thin bone phenotype versus thick bone phenotype. What happens is that actually the cases that have thin bone phenotype, the mucosa compensates by filling in, taking up that space. You can see what happens here. As the bone resorbs, the mucosa compensates and fill that in. So many times when in those cases where in the maxilla that you extracted the teeth, you look at those cases and you see basically the ridge looks normal, but if you take a CBCT, the bone is very thin, because what happens is that the mucosa thickens up to compensate for that loss of that. So what we're trying to do is when we have a thin bone phenotype such as this, we have to think about how we manage these cases. We see that this patient has a very, very thin bone phenotype, and we know that the thin bone phenotype will resorb extensively after extraction. So if we're going to be doing that, we also see that this patient has recession on adjacent teeth. So remember, the biggest risk factor for future recession is past history of recession. Okay? So we're going to extract the tooth using one of these devices that's going to be the least invasive way to extract the tooth, especially if you have a thin bone phenotype. You can damage the bone quite a bit by doing the luxation. So we extract the tooth, and then we use a VISTA technique, vestibular incision, subperiosteal tunnel, and place the implant. And we use tuberosity as our favorite tissue grafting material. We use a little sashimi technique to take that tuberosity, because it's usually very thick. You want to thin it out. And tomorrow in the lab, I'll show you how to manage tuberosity and give you some sashimi skills for that. But you see, when you make this vestibular incision at the time of extraction, it gives you a nice access, because you can, first of all, on that CBCT, it looks like there's no labial bone. But when you use VISTA, you can actually visualize the bone. You can, there was a periapical lesion, you can manage that, and you can place your graft right through that. So you see, we use the VISTA, and the benefit of that, you see, there's no incision at the margin. There's no incision at the papilla, and all of that is intact. So the healing is very rapid, and you see the papilla grows back in, and once you make the final restoration, the tissue is very stable. What is interesting is that in this case, where we simultaneously place the implant, we are able to increase the mucosal thickness, increase the bone because we grafted the socket, and over time you see that the contour remains very well. So in this case, it's appropriate for us, because the socket was intact, to place an immediate implant. But many cases, the socket is not intact. The socket is defective. If there's going to be dehiscence, in my view, it's too risky to do simultaneous implant placement. So Paul mentioned that we developed some devices to manage these cases where we're not going to be doing simultaneous implant placement. One of those devices is called socket cap. Socket cap is the device that you see on top, is intended for covering the opening of the socket. There are 4 different sizes for different areas of the mouth. It's very easy concept because, typically all we have to manage these sockets with is with a membrane. If you think about the anatomy of a socket and a flat piece of membrane, it's just not suited for that. The membrane is not in the shape of a socket. So this is the only device that's available that is actually designed for closure of a socket. And the device that you see below that, socket cage, is a resorbable device that's intended for sockets that have dehiscence. Because what it does is called socket cage. Just like a cage, it's going to keep inside of the socket to prevent the tissue from collapsing. So let's see how we utilize that. You see, we're going to extract the tooth. We remove that canine. You see, this canine has dehiscence. This patient is 80 years old. We want to make sure that we don't do a real invasive procedure. The other technique that you know about, which is the like the early placement protocol, it's very invasive to me. This is very simple. You see the cap, you just place the sutures to that, you place the cap, you get it ready with very light, with loose sutures, so we can place it in very quickly. But you see, this is the cage that's going in. You see, the whole labial bone is gone, all the way to the apex. So first we put the cap on, and then we put the cage. The cage, you see, you have the cap on, this is the cage. And the cage, in this case, we put it in intact, because the whole wall was gone, all the way to the apex. And the shape of it is such that it's kind of like a spring. When it goes in there, it just presses against the proximal wall of the socket to remain in a very stable manner. You just push it in, and it stays there in a stable manner. In this case, I also put a graft. You don't have to graft the socket. You can just leave the cage, because we've done studies to show that the cage by itself actually maintains the contour very well. And you see, the cap was very easy to close it. So it's a very quick procedure and very effective way to manage a socket that's deficient. So if there was no dehiscence, and if we're going to do ridge preservation, we could just use the cap. But in this case, because of that dehiscence, we use the cage as well. So we allow this case to go on for about 6 months of healing, and look at the results. After 6 months, you see the contour was maintained very nicely. And we place, I'm sorry? No. Usually in cases where there's a dehiscence, we don't place the implant simultaneously. There are some cases that I have placed the implant where the dehiscence amount was small and it wasn't in the aesthetic zone. But in this case, we just did the ridge preservation after 6 months.
Okay.
Yeah. Yes, so you see, this is what the histology of that looks. So the cage works. We've published a lot of studies to demonstrate that the cage is effective, it's resorbable. So, to make you the conclusion is that we are so good at evaluating the bone, we're focused on the bone. I want to just turn your attention that as you plan your cases, don't just look at the bone and plan it and leave the soft tissue at the end. Evaluate the mucosa ahead of time. Plan on soft tissue augmentation if you need it, usually at the time of implant placement.
Wow, thank you very much. I was really happy that nobody gets tired and you are so interactive discussing during the lecture and that you're permitted. You see, we have a lot of ideas in this MOI community, and of these ideas coming hypotheses and new food, you say, for research. Of course, you can also visit him and you can also corroborate him on a scientific way or in a clinical way. He's open, very open person. And now we have to eat a little bit faster and drink faster and talk faster. But I think it was worth to have you longer here for discussion. Thank you much again for coming here, and yeah, tomorrow for the course.